Good morning, everybody. Welcome to our 9th web talk of 2021. It's called a deep dive into ACL 2104, strategic planning for your phased return to congregate services. I am Lydia Missalidis, the executive director for the Alliance for Leadership and Education and your host for these weekly webinars. I am excited to share that we have about 550 people registered for this webinar from all over the state, providers, managed care partners, our state partners. We always have a great crew from the Department of Aging joining us. So welcome to all of you. These now twice monthly webinars are made possible by a grant from the Archstone Foundation. We appreciate that. You should have received an email this morning from Pam at the CADS office containing the PowerPoint presentation and 4 additional handouts. They can also be downloaded from the handouts toolbar to the right of your screen. As always, today's webinar is being recorded and will be accessible on the CADS website, usually by about tomorrow morning. Our format is listen only. We do encourage you to submit your questions and comments in the question box, which again, you can see in the control panel to the right of your screen. The audience chat and the hand raising feature are turned off. However, staff can send chat messages to all of you, so keep an eye open for any messages that come from Pam in that chat box. And last, we do value your ideas, your feedback. Do take 5 minutes at the end of the webinar to complete the survey. We read every single one of your comments and questions, and we really value your input. And they do help us build our future webinars. And as you can see from a sampling of the comments from the last web talk, we gave you a sneak peek at the Department of Aging's then soon to be released ACL 2104, and now you do have it in your hands. You've had a chance to study it. Many of you attended the CDA training last week that introduced you to ACL 2104. And there were about 464 people who attended our last web talk. You scored it a 4.8. and commented that you greatly appreciated the sharing, the information, and wanted more and more guidance on how to transition back to congregate services. So we hope to start meeting that expectation today with the deeper dive. So here's our agenda. As promised, we are going to dig deep today into ACL 2104, and also we're going to be referencing, and you'll see in your handouts, a document from the Department of Social Services, and that's called PIN, Provider Information Notice 2121. You can download that from the handouts box as well. And I will mention now, and you'll see again on the resources page, a link to join a Department of Social Services webinar starting today at 1 o'clock, 1 to 3 p.m. that will be reviewing that PIN 2121. So even though it is designed for Department of Social Services license programs, you may all find it of benefit. So if you have time and can tune in, that would be great. They are recorded, but they do not post the recordings. I don't think I've seen one for quite a while.
I'll find you in a minute. I'm on a webinar.
Oh, hey Lois, we can hear you, so we just need to have you mute. Thank you. All right. So while much of the focus today, everybody, is on CBAS, as you can see, we are going to draw on the guidance from the Department of Social Services, and we want to help you all think strategically about this next phase of operating within these contours of what is still a public health emergency. And even though we're focusing on CBAS, as I mentioned, because as health facilities, CBAS were ordered to stop congregating, whereas adult day programs were not. I think many of you are in the same position of figuring out how to get back from suspending in-center operations and planning for an orderly and safe return to more of a congregate setting, which we all know is our secret sauce. So today our brilliant vision team members will share their thinking about how to plan for and implement that safe transition to center-based services. So we've also provided in the handouts box and in your email a paper that the vision team developed. Diane Puckett from Peg Taylor led that effort called Ready, Set, Go, and it'll be a really nice handout for you, for your teams, in a narrative fashion, really walk you through the phases of getting back to congregate services. And we did try to incorporate in today's PowerPoint and in the panelists' presentations as many of the answers to questions that you raised over the last few weeks. So we hope that we'll be able to address many of those today, and we will have time for live question and answer at the end. We're going to get through the presentation first. I'll be scanning questions, and we'll be tossing them to our panelists at the end, and CDA will be joining us at that time. And here's our illustrious panel. You can see Jill and Denise, who need no introduction, and then all of these vision team members who you've met before will be available to answer questions. So we're going to begin with a poll, as we promised you that we would be doing, to kind of keep track of how y'all are doing with vaccinations and with how you're feeling about your readiness. So here's our first poll of the day. You can answer this for us. And what percent of your participants do you estimate are vaccinated as of today? I had our data from last time I wanted to share with y'all. All right, so let's get a few more votes in, and then I'm going to close this poll. Just an estimate. Okay. Let's share those results. So you can see about 3% are showing, 3% of you are showing 100% vaccination. That is up from 1% last time. 62% between 75 and 100% vaccinated. That is up from 56% of you responding with that answer. And between 50 and 75, 22, and that's down, which we would expect from last time. And look at this, only 2% of you are saying less than 25%, and that's down from 3% last time. So great job. I know you guys are all working hard to continue to support your participants who would like to have vaccines. So let's do one more. And now we're going to ask about staff. And then we'll take a look at how that compares with last time. You'll probably have a little better sense of staff than you do participants, but let's take a look. Okay, we'll give it just another few seconds. And I'm going to go ahead and close this poll. About 70% of you have answered. So of those of you on the call today, 25% said you were at 100% staff vaccination. Last time it was 16%. So that is incredible. And 54% of you said you're between 75 and 100. Last time it was about 55, and less than 25%, we were at 7, and now you're at 4. So again, great work, everyone. These vaccinations just get us closer to a sense of being back to some sense of normalcy, right? All right, so we're gonna deep dive, and yes, it's complicated, and we want you to consider as you listen today that you're going to hear over and over again, there's going to be an incremental sort of phased approach. Don't try to do everything at once, and don't wait until the last minute. And as always, be person, family centered. Health and safety are always foremost. The pandemic is not over. And we'll have more news from the governor relative to his June 15th deadline, if you will, or target, I guess would be a better way to say it, for opening the state up across all 58 counties, but that hasn't happened yet. So we still have to be very mindful of the need for continued vigilance, health and safety. And as I mentioned, our vision guidance paper is there to help you out. So we're going to launch into our ready phase of our Ready, Set, Go series of webinars and guidance. And we're going to lead that off with Jennifer, who's going to give us an overview and take us through the initial steps. Jennifer, welcome. We're really glad to have you here today.
Good morning, everyone. Thank you for having me this morning. I wanted to start off with asking a question. I'm wondering if anyone in our audience today felt like me, where I wished that I could just do this like Jeannie and I Dream of Jeannie, or this like Samantha and Bewitch, and miraculously or magically our centers would look like they did maybe in February of 2020. So we know that's not going to happen, and that's not realistic to think that that's going to happen. So what is going to happen? And how are we going to think about it? And so I kind of sat down and I thought, well, you know, let's look at this as an opportunity as we return and move forward to having our participants back in the center to receive services. What can we do to reimagine our centers and look at it as an opportunity to become even better than we were before? So I think part of that magic is to strategically plan for what you want to happen. And there's three areas that I think we've talked about already, and we're going to talk about them again today. And that's looking at your staff and participants, how you're getting them ready to come back, how the staff is preparing to have them back. We're going to again keep talking about facility readiness and always keeping in mind health and safety. And then again, the big one, I think, which is going to take a lot of thinking and meeting with your staff, is the processes that you're going to use in terms of assessments and documentation. So these are all things that we can do as a team together to make this time productive and reimagine our centers for our participants and our staff. Next slide, please. Next slide. There we go. Okay. So I like this little slide right here because it kind of visually gives you some timelines that you want to keep up on. As Lydia said, now is the time to start thinking about what you want to do, because you're going to have to move into the action phase pretty quickly. The month that I really like to highlight is June, because by June 1st, you are going to need to submit your Form 7027 to the state, and you are also going to be beginning to do your first rollout of your reassessments of your participants, with the target in mind. By October 31st, all of our participants will be in the center at least one time a week. So this is a good way to help you in your planning process as you move through the months. Next slide, please. All righty. So TAS is still in place as we move towards bringing our participants back to the center for services. There are some taxes. I don't know why I'm thinking about taxes. We still have another month to turn them in. Tax flexibilities remain through October 2021. And we want to have those flexibilities so we can continue to safely make our plans to resume congregate services. So some of the task flexibilities that can remain in place are less than a 4-hour program day, which will be helpful because as you talk about your facility and maintaining social distancing, your facility is not going to be able to accommodate the same number of people. So you're going to have to start creatively thinking about how you're going to bring back people to your program to be assessed and to provide services. So this will give you a little flexibility in that way as we move forward. Less than full congregate programming. Again, we're phasing all of this in, so you do have a little flexibility there. The important thing to remember, though, is your staffing ratios. It's really important that you do have enough staff in your building for the amount of people that you have in your building at any time during that day. And that's going to be tricky for a lot of people. So you want to really think through how that's going to work for you as you schedule people to come to your building. Monthly therapy hours are waived, but core MDT must be assembled, including therapy staff. So you have a little bit of flexibility in how many hours you utilize, but how many people you have in your building really are going to dictate, you know, how many hours you need to have by all of the different staff. Participants can benefit from in-center and remote and at-home services. So it's important to remember that you might have what we've called a hybrid model, which you will have to provide a lot of training and thinking through for your staff, because I think it's going to be really challenging for your staff to kind of have a foot in both worlds, is what I like to say to my staff. So we were going to be providing some in-center services, and we're going to be providing some home services. How are we going to document that? How do we identify where the needs lie? So there's a lot of questions for you as a team to get together and talk about and train on. And again, you can bring people in on a rolling basis, because we just talked about having to maintain distance and limit numbers. And meals are not required, but should be provided as needed to meet needs. So for example, if you're going to have someone in your program for 3 hours, 3.5 hours, it might be a good idea to provide them with a snack, not necessarily a lunch. I know some centers are thinking about maybe sending a lunch home, you know, a sack lunch home. But as we kind of ramp up more and more, you still will need to be strategically planning for when it's going to be that tipping point, if you will, as to when you will start having to provide lunches. So always make the participants' needs your primary focus when you make determinations on meals. And again, it says right down there, continue to meet participant needs, and you may do so using congregate services in combination with TAS. Next slide, please. So we have an awesome guidance paper for you that I hope you will really print out and maybe have a team meeting and provide some training. I think it's important not just for the leader of your center to know what that guidance paper looks like, but I think it's really important for all of your staff to also have a really good understanding of those phases of transition and how your center, your unique center, is going to be able to manage those phases of transition strategically. So phase A is April 1st through June 30th. The big thing is getting in that CDA 7027 along with a staffing pattern update. That's the ADH6. And you will have to keep turning that in as your staffing pattern changes. So you can expect maybe to turn that in a couple of times, because you're going to be upping the hours of people as more participants come into your facility. You're going to continue to evaluate participant readiness. You're going to continue with your vaccination efforts. I just saw the polls that were done. Congratulations to everyone. I know it's not easy to get folks to schedule them and get the transportation going for vaccinations. But I love the quote that someone said, that no never means never. And I found that to be really true in our center, where folks that we had initially told us that they were not interested in getting the vaccination now have gotten the vaccination. So keep gently providing them opportunities to learn more about the vaccination, because I think it'll be helpful to you. Next slide, please. All righty, the Form 7027 is your roadmap. And I wanted to share with you a little bit about how we operationalize that at my center. What I found really helpful to do was to kind of approach it, this was my approach, was to approach it similarly to how we approached documenting for the, let me just get the title right, the CBAS Home and Community-Based Settings Provider Self-Assessment. I'm sure you remember how we've all been asked to provide documentation as to how we are meeting those different guidelines. And I think it's very similar with what we're being asked to do with the Form 7027. So I created a notebook where I have like the ACL in it, and then I created a policy and procedure roadmap, if you will, of how I'm addressing each of those line items. So for example, under the heading of Review of Center for Disease Control and Prevention of CDC Guidance, I have a line that would say, to ensure that the center remains current with CDC guidance related to COVID-19, including but not limited to the following topics. I listed the topics and then what we're going to do to make that happen. So for example, as the director of my program, I have a link to the county COVID update. So I look at that daily. I attend these webinars as another way to stay up to date. So there's lots of different things that you can put in there to demonstrate and document what you're going to do to meet each of those requirements. And that's going to really help you to strategically plan how you want to approach getting back to congregate services. And I think you'll find that really helpful, and all of your team will be on the same page. I had a training with my staff. We went over this document. I had them sign off that they read my whole little binder, and so that now I feel confident that everyone knows what the game plan is and we're moving forward together. The other thing that I did in terms of the preparing to get back to service planning and reentry is I thought, what is the information that I would like to have a shared understanding and shared expectations with my participants and caregivers as I bring the participants back to my program. And I thought of some different topic areas, and I curated a addendum to my agreement to participate. I called it my agreement to participate COVID-19 addendum. And in it, I have several topics that I make sure I cover with every single adult day healthcare participant and caregiver before they come back to the program, and then they sign it and I put it into their chart. So some of the areas that I wanted to cover with them is I want everyone to have the same understanding that there is no such thing as zero risk of exposure to COVID-19. What we can provide here at the center is mitigations to reduce the risk of exposure to COVID-19. And I wanted to share with the family those mitigation efforts that we are doing here at the center. So I have a whole listing of the mitigation efforts we're doing here to help them understand and feel safe about the return of their participant to our program. The other area I wanted to cover in my addendum was vaccination recommendations. So again, I'm still sending out that same message to our families and participants that we strongly urge and recommend that they get vaccinated as long as it's been approved by their doctor. So I know some people have some reasons why they are not going to be getting vaccinated, so we want to be respectful of those. And then I also let them know that at this time, there is no mandatory requirement at our center that an individual be required to be vaccinated to work or to attend the adult day healthcare center. So I wanted them to have that understanding too. And then finally, what was really important to me is I wanted this to be a shared experience, a shared responsibility, and making sure that our center is safe, not only for their participant, but for all participants and staff. So I did ask them to sign on the dotted line that they agree to conduct a health screening of the participant and any other household members before coming to the center. And I gave them a fact sheet, if you will, that's called, we titled it, When Should I Stay Home? And it's all these different symptoms, and if you have a COVID test pending, different things like that as to when they should stay home, and that these guidelines should be followed, and they agree to follow these guidelines, and they will call the center, let the center know what's going on, and then keep their participant home until we can make a determination it's safe for them to return to the center. So I have them sign that, and I have them put that in the chart. So that way I feel like we've all shared information together. They've had an opportunity to ask me questions, and I can respond to any questions or concerns they have before we start having them come back to the center. So that's how I'm managing the Form 2027. And I would like now to pass on the conversation to Kay, who's going to be talking about vaccinations. Thank you,
Thank
Kay.
you, Jennifer. Good morning, everybody. Again, my name is Kay, and I'm with Commonwealth Adult Day Healthcare Center in Buena Park in Orange County in sunny Southern California. Next slide, please. Today, I'll be talking to you a little bit about some vaccination policies and procedures that you can institute into your center to ensure that vaccinations are being handled appropriately and safely for not just the participants, but also for staff. More of these details can be found in PIN 2121 that Lydia mentioned at the beginning of our webinar, released by the Department of Social Services with respect to ADP programs. And while those, there are some nuances obviously between ADHD programs and ADP programs, there are a lot of similarities and there are a lot of best practices that we can take away. So I do urge you all to read 2121. It's been included in the handouts today. So first off, with respect to participant vaccinations, if you haven't already done so, please make sure to track all of the participants' vaccinations, their first and second dose, if applicable, with the Pfizer and Moderna vaccinations, just to know what's going on with your participants and where their vaccination status is on an ongoing basis. While there's no regulatory requirement for participants to be fully vaccinated prior to congregate services, the center's role really can be to inform, educate, and recommend with giving good information about what the vaccinations are, what they mean, and what the access points are to receive these vaccinations in response to COVID-19. But regardless of vaccinations, the best practices for right now, based on the best guidance that's been provided, is to implement full mitigation measures regardless of vaccination status. So that means that kind of the triumvirate that we've been thinking of with distancing, masking, and hygiene, airflow, and some of the other members of the vision team will be going into that further a little bit later. But even with vaccination status, to exercise precautions and putting in those mitigation techniques to assist, especially when there are participants who choose for whatever reason not to be vaccinated. Again, please remember that being fully vaccinated is not just after the second dose, but it does take a little bit of time for the vaccination to fully come into effect. Right now, the thinking is 2 weeks after the last shot of the second of the 2-dose Pfizer and Moderna vaccine, or the 1-shot Johnson & Johnson vaccine. And another important note that the PIN 2121 goes into further is that because vaccination is a choice, participants should not be discharged based on their decision not to receive a vaccination. This is relevant with patients' rights, with their choice, ability to choose and to exercise autonomy over their own care. So for whatever reason, the participant on their own or but based on the advice of their physician may decide not to be vaccinated, but to be fully aware that those instances may occur, and to have policies and procedures in place to accommodate those participants who choose not to be vaccinated. So whether it's exercising extra precaution with your mitigation techniques within the center to allow for them to continue to receive care. Secondly, in terms of vaccinations, again, this is a very complicated area with staff vaccinations. And while the center is in their right to keep track of staff vaccinations as part of the employee file, this is an area where you really should seek either legal counsel, HR advice, or your insurer to be of the complexities involved with either requiring or not requiring staff vaccinations as a condition of employment. Next slide, please. So screening, while we are still under the task flexibilities, those task requirements of weekly check-in, weekly wellness checks and COVID-19 risk screenings are still in place and still required for our services for participants. Now, there have been obviously some changes that can be enacted, whereas in the past, many centers may have chosen to utilize their telehealth capabilities to conduct these wellness checks and these COVID-19 symptom screenings, because the latest ACL has enabled us to return or to start using congregate services again after submitting Form 7027. It gives us a whole nother modality to conduct these wellness checks and COVID-19 symptom screenings in person. And so prior to starting up congregate services again and bringing more and more participants back to the center, it is good to put a system in place to ensure that this can be done safely and in an orderly fashion. So setting up a system to screen both staff and participants prior to entering the center. There's also some CDC information that's available that's been linked in Form 7027, and putting a system in place to ensure that everybody is screened appropriately prior to entering the center. Other best practices can including signage on your doors to describe what a proper face covering masking policy is, encouraging hand hygiene, distancing, and all of the regular practices that we've become accustomed to in the past year. And also thinking through any other policies in which people maybe entering the center where you may not know what their vaccination status or what their COVID-19 status may be, to have policies in place, which can involve symptom screening at the door, and any other practices that you feel work with your center. And to make sure that you communicate all of these intentions and policies that you've put in place with not just your participants, with your caregiver, but also with their caregivers, to ensure that they feel safe and can make the best decisions about their care, whether they feel comfortable enough to start attending congregate services, or for the moment, in these next couple of months, to stay at home and continue to receive task remote services. It's based on the information that you make readily available. And so in our center, just as an example, we're thinking of ways in which we can set up screening so that there's no bottlenecking, for example, at the door when participants are coming in, to ensure that social distancing it can be maintained throughout the screening process. Next slide, please. And finally, I'll be talking a little bit about facility readiness. Again, this is very much a situation in which every center will be different. Every center has different facility needs and ways in which a facility can be modified. You can see just from these two examples, the top picture is from Elder Day and Santa Cruz, and the bottom is from a picture from Beverly at HC in Los Angeles. And you can see these two centers are very different in their layouts and the way that they've thought of how to, enact distancing, repair their HVAC systems, and it's all very, very different, and it'll depend on the physical plant restrictions that you have in place. But ultimately, Form 7027 will help you to guide your planning into thinking about what kinds of mitigation tactics can be placed into the facility. Some centers don't have windows that can be opened. Maybe there's other ways to bring in air filtration and to improve the HVAC, in which fresh air can't be brought in from the outside. This is also a great time prior to the centers having more people in, with our participants returning for congregate services, to have spring cleaning and to renovate your facility as much as possible, based on whatever your own resources are. And using creative ways to utilize your outdoor space and distancing within the facility. So again, the Form 7027 has all of the resources in place, and this is also a great place to involve your staff to think about ways in which their workflows and the ways and the types of programmatic elements that your participants have been used to in the past, and how they can be adequately modified to accommodate for all of the COVID-19 mitigation strategies that will be put into place. So now I'm going to hand it over to Richard, who will be going further into some of the mitigation.
Thanks, Kate. My name is Richard from Beverly Adult Day Healthcare in Los Angeles. And if we can go to the next slide, I'm going to be talking a bit about mitigation measures that we're putting into place and kind of focusing on for this portion. Can you go to the next slide, please? Perfect. So just to define mitigation, we're talking about reducing risk and liability and severity. And so all the things that Kate was talking about in terms of kind of the trinity of ventilation, PPE, and distancing, all those things have to be taken into account in order to have a safe facility. I think the way that we think about capacity in the traditional sense of an ADA or facility capacity based on the square footage is going to be very different. Right now, we know that we need to stick with 6-foot distancing, and that's not just with seating arrangements, it's also for transportation and assistance. And so I think the biggest measure right now is that we're not going to be doing capacity based on a certain percentage as we're traditionally used to, but it's going to be based individually on each center, and the how is going to be very different from center to center. And so we just want to encourage everybody to keep that in mind when they're making determination of how many people they're bringing in. It's how many people can you transport, how many people can you seat, and how many people can you assist at the same time while you're in center. And so I think it makes it very difficult for most centers to do. And we know that this 6-foot distancing requirement will change in the future, and we're anticipating changes. But as of this point in time, I think we're sticking to the CDC guidance, not by our choice, but kind of because that's what is available at this point. And we want to shield ourselves from any kind of problems or liability in the future. Again, with distancing, this is 6 feet distancing at all times. I think we want to do that as much as possible, not just in the hall, but also in common areas such as hallways or even bathrooms, whether that's by marking off stalls, putting markers on the floor, and then doing something like every other, toilet that we have at the facility, just to encourage that extra space in between common areas or high traffic areas at the same time. Masking, we know that the state still is going to be requiring masking probably for the rest of the year. And so having appropriate face masks worn, again, this is a challenge with patients with dementia or asthma, but this is including inside the center as well as within transportation. So that's a very important thing. With vaccination status, we know that currently there's no exception. I think how we feel after we've been vaccinated and what people such as Dr. Monica Gandhi has told us, that we are safer since we are vaccinated, is very important for us mentally. But currently there is no exception for in regards to how many people have been vaccinated in your center or how many staff members have been vaccinated. So whether participant and staff member are both fully vaccinated or both are not fully vaccinated, the situation remains the same in terms of the capacity distancing and the masking as well. And then just to reiterate, it's a liability issue as well. So we encourage you to seek legal counsel if you need to, and also talk with your insurer just to see what's allowable and recommended. I think it's much easier to make determinations and decisions if you have cold hard facts in front of yourself, instead of going off of this is probably okay, this is probably not okay in terms of operation. Can we go to the next slide, please? We'd like to talk a little bit about assembling your MDT and other staff members when we're returning to congregate services. I think everybody knows every bullet point listed here. I think it's a matter of when we're going to be doing these things. I think it's going to be needed much sooner than we anticipate, since we're having these kind of guideposts put down for June, July, and October. But I think in regards to staff and bringing back staff and training and kind of supporting them through this process is going to be a huge monumental task in itself. And so if we have furloughed staff, then starting to bring them back soon and, kind of supporting them and training them back into getting into the groove of things. I think when you hire one staff member, when you already have a rotating kind of base population, it's a little bit easier for that person to get caught up to speed. But when everybody is returning at the same time, it's very incredibly difficult to get everybody on the same page and to share equal information. So that training and support is crucial at this time. If we're having vacancies in core positions such as nursing, social work, activities, program aides, I think we want to fill them as much as possible, as soon as possible as well. I think everybody agrees that this interim period of hybrid is going to require more manpower than doing one or the other. And so making sure to be able to throttle that work back and forth between departments, and also giving staff members the quantity of work that they will be able to complete at a high completion rate, I think is a very, very important detail as well. I think when we're in hybrid, it's not that we're sacrificing tasks to do congregate services, we're doing both programs together. And so that's, we have to think about workload when we're talking about doing both of the things at the same time. Operationalizing daily staffing schedules. I think we went over the ACL and CDA did a great job of saying that it's going to be a daily requirement. So how we traditionally think of staffing ratios, that's going to apply to whatever's happening in center. And then we also have to take into account what we're doing via tasks, because at the forefront, it's basically based on what the participants' needs are. It's not necessarily the minimum of what we need to do. I think everybody really wants to know, okay, so what do I need specifically? But again, that's going to be case by case depending on your individual facility as well and the needs of your participants. And then we all need to know that we're all going to be coming back to the center. I think that's a really great thing to think about, that we're all going to have a team together, we're all going to have our participants together. But I think it's just a reminder that this current model of working from home and serving participants remotely is not what CBAS is designed to be. And so to have the expectations by staff that we're going to return to the work site, we're going to be working together, the participants are going to return, is a very, very important point. And with that, I'd like to turn it over to Lena for any additional comments about the MDT and also to take us into the nutrition.
Thank you, Richard. That was very informative. I think you covered everything. One of the biggest takeaways from all of this is to prepare the staff and the participants beforehand so that there are no surprises. Next slide, please. And that's a good transition when we're talking about nutrition services. So again, with the flexibility, each center should really think about their population and the needs of the participants when thinking about will we be serving meals? How will we be serving meals? How many meals will we be serving, or beverages in that matter? So how you need to visualize how will that look when there should be 6-foot distancing, and face coverings can be removed. How well do they set them on the table? How do we make sure that masks are not mixed up amongst participants? Again, going back to having enough PPE, they might fall on the floor, etc. But definitely thinking in a person-centered approach as unique to your own center as well as to each of your participants. And again, I want to emphasize making sure your participants and their families understand the transition phase and what they should expect when they are within this transition phase when it comes to meals and the assessment process before we get back to full congregate services. And with that, I'm going to toss it back to Richard for transportation.
Thanks, Lena. Just to go a little bit deeper into transportation, I think this is probably going to be the biggest source of bottlenecking when we're returning to congregate services. I think when we think about capacity and how many people we can seat inside the center, that's fully important, but getting people to the center, I think, is even more important and even more difficult, especially since we have to abide by the 6-foot rule. And so if we take into consideration a 25-passenger bus and we're seating every other row, one person per row staggered, it basically means that for each individual 25-passenger bus, we can seat a maximum of maybe 6 to 8 people, depending on the spacing and the arrangement of seats. And so taking that into account, we want to make sure that programs are prepared and also are scaling up in regards to kind of the allowance that they have in terms of transportation. I think we want to supplement our own vehicles by using different, providers that are available, and also family members and caregivers where they are. I think in the initial stages, it'll probably be the case where we're having people brought in via taxi, family members, and kind of other caregivers that are available in order to do the assessments to get everything done on time, since we are on a kind of a tight schedule. But I think even with transportation, the kind of benefit is that we know that these guidelines are going to change, and they could even change, tomorrow or the day after, and that we're imminently kind of anticipating returning to kind of a little bit of a, flexibility in terms of that. But at this time, we just want to reiterate that it's still 6 feet. And so I think a lot of people have hesitancy to start. I think Kay put it very aptly yesterday. We don't want perfect to be the enemy of good. We know that there are a lot of challenges, especially with transportation. How can we serve, for example, 200 people if we can only fit 6 people per day? But that's the reason why we have this transition period. And to start that in the month of May, June, and July is going to allow us to be able to handle the increases when they're allowed by the CDC and kind of California as well. And so again, 6-foot distancing is required, and everybody recognizes that it's a huge challenge to do. But again, supplementing that together with other providers in paratransit, which Rainika is going to get into right now, is going to be the most important part. So Rainika.
Thank you, Richard, and good morning, everyone. I must say I am excited to be here and to be making plans and preparations for returning to congregate services. And I want to share a bit more about how we've been preparing for transportation. We've been working with our paratransit agency here in San Francisco, and I'm really excited that our paratransit personnel did actually attend the last CATS ALE webinar on April 7th, and we're really well informed about what we're thinking in terms of transportation, and we're actually working together in partnership to discuss logistically how we're going to resume services. So it's important, if you're able to do that as well, to determine what your paratransit agency's readiness is and learn from them how much time will they actually need to reorganize on their end to begin providing group van services for your center again. For example, would it be 30 days in preparation on their end, or would it be 60 days in preparation on their end, or whatever it may be, because that's important for you to know and be able to gauge when you can even start using the service for your participants. Another important point that I've actually run into a bit is participant eligibility. If you may have enrolled new participants under TAS, you may not have actually done an application for paratransit because they weren't coming to and from the center during that time. So that's something you may want to check on. You may also want to check on if there's been any of your currently enrolled participants who may have expired. Their eligibility may have expired and you need to resubmit the paperwork. I know I have a handful of participants that I need to do that for now. And again, due to non-use of the group van services, you want to update all the different records and lists and things that you want to be aware of as you're making those preparations. And you can actually begin doing that now, even before you formally or officially submit your CDA paperwork. So I really encourage you to begin, if you haven't already, talking with your paratransit agency and figure it out together. Again, this is all very new, and we're all doing our best to comply and follow the CDC guidelines. Next slide, please. Also, when you're working with your transportation agencies and for us paratransit, share what your program hours are going to be, because that's extremely important as well. Is it going to be a 2-hour time frame to begin? And as you're working through different phases, will it be 3 hours? Are you going to have staggered drop-off times? How many days per week are you anticipating doing this? That's important for paratransit to understand, because they're, again, going to need to be able to schedule the pickup and drop-off times. And they are going to need to determine realistically how many trips can they do based on what your specific program hours and participant arrangements are. You're gonna probably need to recreate new routes as well. So again, if there have been new participants who have been added to your program or people you may have discharged, so all of that's going to look very different. So you might consider working with your transportation agency to pick up in same regions or neighborhoods, and also, again, fewer participants are going to be able to ride the buses at any given time. So that means there's going to be more trips to and from your centers. And for our participants, we definitely want to cater to their needs and work with them and be as person-centered as possible. But during this time with these restrictions, you may have to explain to your participants and your families that you're not exactly able to cater to when so-and-so has to go to work, or when the caregiver is what their schedule is, even though it is extremely important, as we all understand, who's going to help our participants get onto the van in the morning, and who's going to be able to, or whatever time they come to your center, and who's going to be at the home or the residence to receive them when they're leaving the center. So all those things are important that I know we've experienced and have dealt with in the past, but even more crucial during this time as we are working again under the COVID restrictions with the CDC guidelines. So again, these are just some things to be thinking about, and you can start doing that now. A lot of it can be done again prior to submitting the CDA 7027 form. And definitely, if you haven't already, begin having the conversations with your transportation agencies. And with that, I will pass it on to Lois, who's going to be sharing more about evaluations. Thank you.
Sorry. Good morning, everybody. I'm Lois. I'm the program director at Elder Day, Adult Day Healthcare here in Santa Cruz. And we're going to switch over from talking about the facility to talking about our participants, evaluations and assessments, and documentation. This is all things that I know my team have had a lot of questions about, and we're still in process with kind of getting it all sorted out, as I imagine you are too. But we're starting out with, first of all, clarifying what is an evaluation and what is an assessment. Our vision team really spent a lot of time sort of struggling with this and turning it over and kind of figuring out. We're so used to talking about assessments and reassessments as CBAS centers. And then when we added this whole term evaluation, what really does that mean? So when we're talking about evaluation for bringing people back to congregate services, what we're talking about is an informal process. And so it's not our formal assessment and reassessment process, but it's a process that helps us figure out if it's safe and when it's okay to bring somebody back to congregate services. And that is something that it's not, you don't have any forms for that. You don't have any official way to do that, but you might want to create a form for that to come up with the kinds of things you'll be thinking about to bring somebody back to the center. But we started out at our center, and I would suggest that you come up as well with some sort of triage. At the last webinar, I presented the triage tool that we used, and I believe that's in the handouts for this week as well. But determine who you need to evaluate first, like who are the most important people to bring back. And then once we completed this triage tool, deciding who had the most need from a social standpoint and a medical standpoint, then we started evaluating those people. And the way we did that here is that our nurse is bringing the participants into the center. Usually our transportation people are bringing them in. Sometimes family members are bringing them in. And she's doing a hands-on evaluation to make sure how they're doing. And then our social workers are doing their evaluation remotely the way we're doing most of our services. At least they are right now. They may be doing it more person to person once more people start coming in for the evaluations. And then once you finish that evaluation, you need to triage again, because what we're finding is some people may have more need, some people may have less need, and some people may not be ready, emotionally ready to come back to the center. We're super fortunate here that 100% of our staff and 100% of our participants, yay, just a couple days ago, are now vaccinated, so we have less worry in terms of that. But there still are families who are worried about having their family member come back to a group setting. So again, that's evaluation. And assessment or reassessment is that process we all know really well. That's something that we all do. We know how to do it. And we do an assessment the first time we meet somebody. The assessment includes a home visit. And then we do our 6 monthly reassessments at the time the TAR needs to be renewed. Everybody knows that process. So we're really trying to be careful to make a distinction between evaluations and assessments or reassessments. Next slide, please. Next, oh, there we go. And again, the evaluation is a less formal look. It's a way of meeting with participants, meeting with family members, either in person or on the phone, and deciding what their needs are. And these are the kinds of things that we're talking about, and you may have extra things that you'll add on to that list, but the things we're talking about here is their first question is, what's different? What has changed since the person was last here? It was over a year ago that our participants were here at the center, and even though we've kept really close contact, as I know you all have with our weekly check-ins at many different levels, our participants are really different, and as we're bringing them in and evaluating them, we're seeing that there are really big differences. So that's what we're trying to look at. What's really different? The other thing that we're asking people is, what are you concerned about? Coming back to the center. What we're hearing more than anything is we're concerned about not coming back soon enough. But still, some people have some concerns, so it's good to ask about that. And then again, we're seeing lots and lots of need for people being strengthened. There's so much deconditioning from people being a year away from the center. And then we also need to think about when people come to the center about fall risk. Fall risk is probably much, much higher for a lot of our participants. The other thing is that almost everybody who's taking meds, which is almost everybody, may need something different about their medications. We may be keeping track of what's been happening with their medications over the last year, but when they come to the center, do they need med administration that they haven't had before? Do they need something changed? It's really important to think about that. And again, we need to think about participant readiness. If people are terribly deconditioned, are they going to be able to sit on the bus and come to the center and be here for a 4-hour day? I think many, many people won't be able to do that. And then we'll need to modify. So some people who are 5-day-a-week people may be coming 2 days a week with a day in between to rest, or they may come 3 days a week. As we're assessing people, that's what we're figuring out. I'm sorry, as we're evaluating people, not assessing, evaluating for return to the center. And then the other thing we need to think about their transportation plan. I know some of our families aren't comfortable with their family members coming on the bus, and they want to bring them themselves. And of course, that's perfectly fine. And then again, we have to think about if people are able to get on or get off of the bus, and if they can tolerate the time on the vehicle. I know some of our people end up sitting for fairly long periods of time in traffic on the way here. Yes, we do have traffic here in Santa Cruz, unfortunately. But you need to think about that, if they can, how much time they can spend on the vehicle. This is this one piece is really important, and I think it really deserves emphasizing. Evaluating a participant for coming back to the center does not change the TAR date. Think about it as if somebody had been away for a period of time. Say somebody was in the hospital for a month, or in the hospital and rehab for a couple of months. You have a process when they come back. Think about that. It's more like that. It doesn't change the TAR date. That's a really, really important point. Next slide, please. So, as we start getting into, now I'm going to be switching over and talking about assessment and reassessment. For assessment and reassessment, you have to start your full MDT process, meaning you need your whole team reassembled by June for starting the TARS in the usual way, or the IPCs in the usual way for July 1st. So remember that. You have to actually have your MDT assembled and working in June. We're actually doing that for May, so we're really ready to go for July, and making sure everything's ready for July. We're starting our full MDT process in May. What is really, really different here is that, as opposed to using boxes 15 and 16, which I think many people have been using for their tasks of reporting, what we'll be doing is doing our care plans the same way we used to do them in boxes 13 and 14. That is what is really, really going to be different. We still can use boxes 15 and 16 sort of the way we have in the past for any additional information, if there are any changed circumstances, but also for letting people know. So remember, when you're completing your IPC, you're completing it for your managed care organization and for the surveys that you have from the CDA, in addition to, of course, your care plan for your participants. So remember that you're talking about what's different. You're talking about talking to somebody as managed care who maybe doesn't know the participant as well as you do. So you need to explain why you're doing maybe 2 days of in-center services and 2 days of remote services for that person for a period of time. So make sure that you describe that in boxes 15 and 16. Also, while you're doing your full MDT process for your reassessments, this is an official reassessment, make sure that you get medical records if you haven't gotten them already. I know a lot of people do get them as they've gone through tests, but make sure you have medical records and you really understand the person's new medical situation. And again, it is way better to do an in-person regular formal reassessment, just the way we would have done back in the old days, but sometimes you'll need to do it in a different way. You might do it at the person's home or have them come in briefly to the center. There are different ways you can do that. And again, reassessments, as always, will be completed on a rolling basis based on the due date, just the way we've always done them. So for the July 1st dates, for everybody who's due for their reassessment, on July 1st, you need to make sure that you've reassessed them during June and you've completed the IPC by July 1st. So June is the time to be getting ready for your July 1st using of your boxes 13 and 14. Next slide, please. And again, you're going back to your regular documentation, as I said. So make sure that you've gone back to using boxes 13 and 14. And again, I said it's what managed care and the CDA will be using in terms of surveys. Make sure you do your best to reflect the frequencies. This is something we're finding really tricky to sort of conceptualize and get clear, is that, for instance, if somebody is coming to the center 2 days and get remote services 2 days, your care plan you're going to have 2 care plans. You're going to have a care plan for in-center services and a care plan for remote services. And you need to say what you're going to do and how often you're going to do that. And the other thing is that you may find that on July 1st, you have some participants who aren't ready to come back to the center. So your care plan will say, this is what we'll do when they come back to the center. But meanwhile, they will come back to the center on such and such a date, or they're expected to come back at such and such a date. Your care plan will reflect that. It will reflect whatever your plan is for the next 6 months, whether that's having the person in the center the whole time, partially in the center, partially remote, or if they'll be coming back to the center at a later date. All of that needs to be in the IPC. And again, this is, as everybody else has been saying, this is just figuring out as closely as we can. This is a new process. We haven't done it before, and do the best you can with it. It doesn't have to be absolutely perfect, just do the best you can. Also, your other documentation should go back to all of your regular notes. You're using your IPC, your progress notes, and your flow sheets in the same way you did before. Also, the last thing is make sure that it does include your plans for returning to congregate services if they aren't starting right away. And that is, yes, that is all that I have for right now, and I'll turn it back over to Lydia for Q&A. Oh, no, it's not. I thought I had one more. Sorry, my apologies. Yes, there are just a couple of words about people who were enrolled during TAS. I know some centers have enrolled a few people, some have enrolled many people. Make sure that prior to resuming congregate services, before the person comes back for congregate services, you have obtained a TB clearance. That's really, really important. The other piece is that if a person has had a COVID vaccination recently, you need to wait at least 4 weeks after that has been completed before you do the TB test. So make sure, I think your nurses will be keeping track of that. For people enrolled during TAS, their reassessments will be due at the same regular TAR date as always. And then just remember that the ACL 2104 makes an exception that lets us conduct home visits in a different way than in person. But if possible, for anybody who is coming back to the center, do your best to do an in-person home visit if you can and get that up to date. Otherwise, have a look at ACL 2004 and can see the exceptions that we still can use because we still are under TAS. And now I really will turn it over to Lydia. Thanks, Lydia.
Yeah, thank you, Lois. Thank you to all our panel members, and I'd like to invite them all back now to come on screen, and we'll open it up for some conversation. Fantastic job, everyone. I just want to thank the Vision team members, and that includes Denise and Jill and all of these people, plus others who are not on screen today and who you've seen in other webinars, because we have literally spent at least 2 to 3, sometimes 4 hours a week noodling through all of these issues so that we can give you some kind of coherent guidance and help you operationalize what you see in the Department of Aging and hopefully soon to come Department of Public Health guidance for all of you. So been looking at questions coming in. Thanks, everybody. These are fantastic. Keep them coming and keep them coming in your survey as well. And also topics for future webinars. We would love to hear from you what you think are the next high priority training topics. So I think we've got everyone on. Let's see if we see Department of Aging. There you are. You were hiding behind my little screen there. So welcome, everybody. Let's start off with a couple of questions for Jill and Denise. One has to do specifically with staff and submitting revised staff roster. Can it include staff who are hired but who have a start date that's in the future? In other words, prior or after the time that that they want to get that submitted to you. So they're lined up and ready to go, but maybe their start date is, you know, July 1. Is that something you've thought about, you know, or do you need to get back to us on that?
You know, I don't think we've. That's the first time we've gotten that question, Lydia. I guess
Okay.
my initial thought response to that, not fully formed, but part of submitting the CA 7027 and the new revised staff services arrangement form is that the center is attesting that they are ready to begin congregate services, and CDA would be approving it. So. So in the case where perhaps they may have the person hired, but they're not starting for another month or so, at that point, they're not quite ready to begin congregate again, depending on, you know, the staff and all that and what they're looking at. So that's kind of my somewhat incomplete answer to that. But I guess as a rule, I would say, you know, wait until, you know, if you're looking at a general rule would be submit that the 7027 and 8806 when your staff is on board and you are ready to go. So once CDA approves that, you're set and you can start right away.
Great. Okay. Thank you for that, Jill. And for TB tests, we've had a couple questions come in on TB test. Could you clarify that that is only required for new participants who have heretofore not had a TB test but were served under TAS, or who are brand new participants coming in from today forward? It's not required for all participants, right?
That's correct. It's for new participants who have not been previously served, who have enrolled during TAS or not been previously served at the center. Yes.
Okay, very good. So to my panel members, we've had a ton of questions, and I include Jill and Denise in this too. We've had a ton of questions come in around 6-foot distancing and how the heck are centers expected to maintain 6-foot distancing when they're bringing people in for hands-on care. By definition, hands-on care means you can't distance. So I'm wondering if maybe starting with CDA, you could give the audience a little bit of a sense of what you've been doing relative to some guidance from CDPH, and if others of you have some thoughts about how you have been managing safe hands-on interactions with participants. Of course, we all are aware of standard precautions. We know that we're all supposed to be following COVID-specific precautions, but just want to open that up for who'd like to kind of lead that off, that conversation.
Yeah, I can just speak real quickly. I certainly recognize that definitely, you know, providing personal care or any type of care for participants at the center requires probably that you're going to bridge that 6-foot distance there. So understandable. And, you know, I think, like you said, Lydia, you know, the assumption is that staff would adhere to, you know, standard precautions and use of PPE while providing that. And again, we're working with CDPH to get additional guidance on, you know, kind of what that looks like, what their specific requirements will be in center for that moving forward. But I think that generally that's the understanding is that, yeah, you would not be able to maintain that 6-foot distancing during, you know, provision of personal care or other services, whether it's hands-on like PT, whatever that might be.
And
So
if I could, I'll tag on just a little bit here. Good morning, everybody. Denise. I just wanted to say that I think that you know, as the vision team has approached a lot of these subjects for the last several months, that we have been sort of sending up a hope and a prayer that this is not a forever proposition. This is going to be a temporary, you know, stopgap measure over the next few months, and that we will find ourselves in a place where there's less restriction, in particular for levels of vaccination, and if the disease spread rates come down as we anticipate. So I guess I just want to make sure I threw out that positive note that we are hoping that this is a very temporary thing, and that when we find ourselves in October, that we're not going to still be in this 6-foot distancing thing. We know it's going to be a difficult proposition in the meanwhile.
And do any of the other vision team members have some suggestions for addressing this question as people are being brought in for services right now, maybe on an individual basis? What kind of PPE are you using and how are you handling that?
I can tell you what we're doing right now. We're just using, if we're not expecting any splashes or anything like that, nobody is gowning up, and they're not wearing a face shield. But if they're getting closer than 6 feet to participants, they're wearing N95s, and certainly doing any kind of personal care. They're using gloves, and we'll be using face shields again if there's any sort of splashing.
Okay.
So
and the face shields are for
PPE on hand.
Right, I was going to say you can still be ordering PPE through the state. I don't know what's available right now, honestly. And then the face shields are for protection of eye, any kind of fluids or close contact where you don't have other eye protection on. So just be aware of that. As Denise said, this isn't forever, everybody, and we are all working hard. We are, as well as CDA, to get CDPH to get more specific on some of this guidance so we can be really clear with everybody. So Jennifer, a couple of people asked if you'd be willing to share some of those forms that you mentioned, the when should I stay home, for example, the family review document. So if you've gotten that, for example, on the internet somewhere, maybe you can pop it in the chat box. If not, we'll try to get some more forms from vision team members to share.
Right.
Here you are, Jennifer.
Yeah, I can try to pop it in the chat box. My challenge is always my technology ability, so I will throw that out there, but I will try to give it a go.
Yeah, whatever is available that you're willing to share, we can get to Pam and she can get it out to everybody. So thank you for that. Also, transportation, kind of a similar question around transportation. So Renika and Richard, thank you for sharing your experiences and advice. I guess what I would ask you is sort of what are the 1 or 2 top things that you would advise relative to working with other agencies, Renika, where we had one question come in, one example where, for example, their transportation provider is not doing temp checks before people get on the bus. So just some thoughts about how you're going to be managing that.
I would say if the transportation agency is not going to do something like temperature checks, to figure out a way for the center staff to do that as a part of the screening. So I know many of us may in the past have, I know we would usually call certain participants every morning before they would come to the center. So that could also transfer over to now. There could be a designated staff person who could do the screening, and if there may be a need to provide some of the more inexpensive temperature checks to a participant so that they can do it, or their caregiver or family can help them do it at home before they get on the bus, that may help. And then of course they have it again when they arrive to the center. But I would suggest maybe doing some of those things, and again, doing that screening possibly with everyone who's expected to come into the center on a certain day prior to them even getting onto the bus, to make sure they still are coming, and all those different things that we usually do early in the morning before participants come.
So adding that screening. Yeah, Richard, anything else you want to add?
I think in terms of transportation, one of the important things is being able to figure out, especially if you have your own drivers that are delivering meals at the same time, coordinating the pickup and drop off of participants that's happening in conjunction with that. And so one of the ideas that came up recently was that people would do the in-center earlier in the day and then transition to doing tasks in the afternoons when deliveries were freer to do. And what we're probably going to do is do it in conjunction, at least at the same time, where we're picking up the participants prior to making the daily calls to everybody, having them inside the center and staff designated to care for the participants inside the center. And we would be sending them home with packed lunches, as our other lunches for the task deliveries are going out. So we wouldn't have to duplicate the rides that are going out to drop off people and then go do the deliveries. They would be happening at the same time. Mostly in Los Angeles, it's possible because most people live in large apartment complexes, at least for our population. And so the people that we're dropping off, there would potentially and realistically be a lot of people that we're dropping off meals to at that same location. It might obviously differ for individual providers, but there's that kind of approach as well. There's a split approach of doing it at 2 different times so that you have staff on hand. And that might be a little bit easier for centers that are running at very minimal staffing right now. But for people that are scaled up and already have most of their MDT on site, they might be able to do it at the same time. So providing services inside the center and then sending everybody home at the same time.
Okay, some great operational advice there. A lot of questions around vaccination, not vaccinated people, what they can and can't do. I just want to say we don't have good answers for you today, everybody. We are desperately trying to get them to you. We're trying to get some exceptions for people who are vaccinated. We're going to need more conversation with CDPH on that. So in the meantime, what I'm really enjoying about the questions that are coming in and the comments is you guys are really beginning to think strategically ahead. And folks are thinking all the way out through October, which is fantastic. But also take a step back and bite off what you can right now and plan out your steps, as Jennifer described so beautifully at the very beginning and Lois did, relative to your evaluations of people and who's really urgently needed to have an eyes-on look to see how they're doing. And all of these questions that are coming in that we can't answer today around distancing and masking and so on, believe me, we are working overtime to get those to you. So stay tuned for that. And I do want to also ask all of the panel members just quickly relative to your communication, which I think is so important right now with participants and families as you're beginning this phase. What are you saying? How are you communicating to people about coming in? And I don't want to get ahead to October. We're going to save that for another webinar because more guidance is coming from CDA about October. So let's just focus on the closer to home right now. So let's start with Renika. How are you communicating and what are your main messages?
We are communicating via telephone and also when we talk to our participants over their video tablets. I know the question from them and their families we've been hearing all year long. So we are pretty excited to be able to say now that we are making preparations for resuming Congregate in-person services hopefully by the summer is sort of what we're giving. We're not giving any exact dates yet. And when I do have more of an idea of an actual begin date, I will send a formal letter out to participants, but I just don't want to do that yet because we're not quite ready. But we are, and also in addition to sharing that message, we're talking with participants very informally and generally around what time they think they could possibly be ready to come to the center in terms of the day. Is it, because I know I was thinking about maybe a 9 a.m. start with different staggered times. And for some of our participants, that would mean getting onto a bus or getting into a car or taxi before 9 a.m. And if they haven't been used to doing that, that may not really work. So rethinking some of my ideas and bouncing it off into what participants' readiness is sort of what my staff and I are doing now as well.
Okay, that's beautiful, Renika. Thank you. Richard, how about you?
Sure. So we're doing everything kind of in the form of this newsletter. We have a newsletter go out every month just to kind of update our participants and staff members and families. But we're going to start sending one out at the beginning of May in terms of giving a little bit more concrete timeline. Like Renika was talking about, nobody had any idea over the past months of when exactly we're going to be able to return. But now that we know, we can start to broach that subject with the participants and families and at least let them or give them time to react to it and kind of accept the fact that we are coming to the crossroads to where we're going to start doing more stuff in center. I think that's a little bit different for staff as well. For staff, I like to bring it in a little bit closer and say, we're probably going to be doing this within the next month or two, so that they can mentally prepare a little bit more in advance. And so I think there's a disparity there of how we're communicating to participants, but also at the same time staff, and making it a little bit more of an urgent task for staff.
Great. And Kay, and how are you communicating?
Yeah, just echoing a lot of the themes that Renika and Richard have both spoken about. We have been incorporating a lot of more targeted questioning and triaging during our wellness checks with our participants, and reviewing and evaluating all of the information that we've gotten from our participants over the past few months, especially with how they're feeling, what their readiness is, whether they've deconditioned or not, and essentially going through a triaging process with our entire participant roster to try to figure out for scheduling purposes and for actual implementation logistics of which participants would be the most appropriate to come more quickly, and others who are a little bit more reluctant. And so their starting of congregate services and in-person assessments may be a little bit later along in our timeline. So it's more of just evaluating participants where they are and trying to meet them where they are, which is helps us with our own planning and our own scheduling processes, because we want to make sure that we have enough staff available based on what the participants will need when they do come into the center. And then we've started just among staff. I mean, my staff is much better at figuring out logistics and all of the nuances of transportation routes. So it's really kind of being very collaborative and giving those general guidelines based on all of the CADS ALE web talks, as well as all the CDA guidance. So internally within staff, we've tried to plan out some of the timeline, but we're not really giving it to participants yet, because we want to be absolutely sure, rather than giving them potentially false hope or false worries, because we need to change things on the fly based on whatever new guidance may or may not come out.
That's great, Kay. And this is exactly why this takes months of planning. It's always harder to exit a public health emergency or any kind of emergency than it is to enter it, right? So we're appreciative to the state for giving this longer runway to get back to congregate services. So just quickly, Lena and Lois, we've heard from Jennifer already. So go ahead, Lena, real quick.
We are also using the weekly wellness packets. I include a letter from myself every week with updates, because things were changing daily, weekly. So from the get-go, I was doing weekly letters, and I just give everyone a heads up, the participants and the families, what to expect, and if there were any changes, then there were any changes. And during our regular staff meetings, which happens every 2 weeks, I give the staff talking points and have them make sure to be ready to present with feedback for the following staff meeting. And the talking points also include things that they should be sharing with the families, updates, changes, what to expect as we transition and ride the COVID wave.
Okay, great. And Lois, real quick from you.
Just really quickly, we're doing a lot of what the other centers are doing. Certainly at our weekly wellness checks, we're letting people know that we're expecting changes. And as we're bringing people in for evaluations, clearly we're explaining that we're bringing them in for evaluation to get ready for opening for congregate services. And I'm putting together a letter, but I'm not ready to send it out until we are really, really clear, until we know exactly what our dates are, because in the same way, I don't want anybody, our participants are so eager to get back. I don't want to disappoint anybody by giving them wrong information. So as soon as I'm clearer about exactly our dates and when we'll be able to do things, then I'll send out a letter to everybody.
Okay, great. So the message, I think, from Vision Team is communicate, communicate. Don't raise false hopes. Don't get people worried, but keep them looped in. And this is a great opportunity to have those conversations that you guys have just described. Could you clarify, Jill or Denise, is a new fresh H&P required upon the 6-month RETAR reassessment, or for the reassessment?
For continuing participants, no, that it's not required. I think I'm correct on that.
Denise, I'm going to have, I
Yeah.
think typically we're not requiring, am I correct on that?
Yep, that's correct. And again, I think it's, I think Lois said it, maybe a couple of others on the team today, that to think about how we always have operated in our centers when we have someone who is out for an extended period of time. If there's some significant changes or needs, obviously the liaison with the physician is always required, but that at reassessment time for those continuing participants, it is not. But for the new participants, it would be.
Okay, and I think it was mentioned by someone to get medical records for people, especially new folks. New folks do need the history and physical. So if you don't have that already, that should have been done upon enrollment, but nothing has changed relative to that, and the communication with primary care and other health professionals and their circle of support, as we call it, is really, really important. So let's see if there's a couple other just quick questions here. A number of questions that I know we're going to address in another webinar, everybody, is masking and participants distancing and masking and ability or inability thereof. So we'll definitely, we do have some ideas, but we'll talk about that more fully, I know, in a future webinar. Right now, just do the best you can. And I know there are also alternative kinds of masks that maybe people would feel more comfortable wearing, that you can investigate on the internet and, you know, try those out or give people some other options so that they can be comfortable. I'm not sure that I've ever worn a face covering for 4 hours, for example, and how I would handle it. So I think this is something we'll all be learning from each other about and sharing. So if you do come up with some really great ideas, please do email us and share them so we can pass those along. Okay, so let me take another quick scan here. There were some other questions that I think are a little further down the road about October, but more guidance is coming, as I said, and let's just take it a month at a time right now. Testing prior to readmission to congregate services, that is not currently a requirement. We know that there are some rapid tests available now, but they do still cost some money, and it isn't required, but you are required to screen. So the usual screening for COVID signs and symptoms you're all very, very familiar with. You'll still want to be doing that, but as of now, there is no requirement for testing for staff or participants. All right. N95 masks are not required. And at this point, again, we need CDPH to weigh in. So what you guys have provided us today in your comments and questions will help Denise and Jill and me to bang on that door a little bit louder and get them to help us out. I know they're super busy over at CDPH, so we understand, but we do want to get people back to center. There's also some questions that have come in we can't address today. There's not enough time, everybody, but there's a lot of stuff on the internet about what to do in case of suspected COVID or infection. And again, the Department of Social Services PINs have addressed that in the residential setting, the community setting. So I would, again, recommend that you take a look at those. So we're about at closing time, everyone. I want to, again, thank these fantastic panel members. You did a great job today sharing your information. We'll keep at it, everybody, with Department of Aging to bring you further guidance and sharing practices, but also please feel free to share any great ideas you've come up with as well. We want to hear from you all. You know how to reach us, Lydia@cats.org, Pam@cats.org. You know how to reach Department of Aging. So get us any ideas that you have. So let me thank you, and we're going to go on, Pam, to the next webinar. So salute everyone. We'll see you next Monday for a Vision Talk meeting. We're going to do one more quick poll before we let you go. Let me find my, oh, what happened to my polls here? My polls have disappeared. Hang on a moment. I want to do this last shot. Here it is. All right, one more poll, everybody, before we let you go. So this is the same poll we provided last time based on what you learned today about returning to congregate services. How do you describe your readiness? Let's go ahead and answer that. We'll see if you feel more ready or less ready than last time. Okay, I'll try to get our percent up. I like to be at least 60% of people voting. We're at 54 right now. Okay. I'm going to go ahead and close this poll in just a few seconds. Votes are still coming in. All right, I'm going to close it right now. So here we go. 28% of you feel like facilities ready. Last time it was 25% of you. Staff, 33%, last time 35, so about the same. Participants and caregivers, 44, last time it was 54. And not ready but actively planning is about the same as last time, and not ready and need more resources, 7%, last time it was 14. So, okay, a little bit of movement there, but this is complicated. We understand completely, and that's why we're here trying to give you guys some help. So we'll go on to the next slide, resources. This is a good resource for you that we've discussed previously, so I'll move on from there. Reminder again about the Cal OSHA standards, great template for you to use, will help you prepare for the Form 7027. Next, Pam. And a couple things here of importance. Today, again, Department of Social Services PIN 2121 training. I think it'll be helpful for all of you. Dr. Louise Aronson from UCSF is one of the presenters, so she'll answer questions about COVID. If you have time, tune in. May 12th would be a normal web talk. Would not be a normal web talk. CADS is providing a webinar on communication and behaviors, coping with challenging situations in dementia care with Rebecca Wilson. You'll see that coming out by Friday from Pam, and we're hoping that Rebecca can address some of the questions that you guys have come up with relative to, for example, mask wearing and distancing and so on, that she might be able to help us think that through a little bit more. So we're going to skip our May 5th web talk, because I need a little bit of time off, but we're going to be gathering up a lot more information for you and maybe in touch with you by email with some forms and some other ideas. So stay tuned for that. And then as we see your feedback, we'll announce our May and June topics. We know we're going to be deep into getting ready for July 1. And next slide, we're going to go ahead and close with my usual thought for the week. This one came to us via Jennifer Hurlo-Payanessa, who's also a fan of quotes and inspirational messages. So this one is: a wise man adapts himself to circumstances as water shapes itself to the vessel that contains it. And this is an ancient Chinese proverb, probably attributed to Confucius. I'm just going to say it is. And it reminded me of how a clay pot is shaped on a potter's wheel, and it goes from this shapeless lump to any one of an infinite number of shapes that will hold something dear and precious when it is finished. And you all have had to adapt to the ever-changing shape of the pandemic, and you're not sure what it's going to look like when it's over. You've got some ideas, but it's still taking shape. We just know you've done a great job of adapting to the circumstances and reshaping what you do to keep people safe, healthy, and connected. So keep up the good work, everyone. We'll get through this together. As always, thank you for joining us. Stay safe, and see you in 3 weeks. Take care, everyone.